Yes, good afternoon. This is Dr. Rajasekhar. I am a liver transplant surgeon and I am a visiting surgeon at Lakeshore Hospital in Cochin. I am given a topic of acute liver failure, and acute liver failure is a increasingly recognized problem. Particularly, it does not specify to a peculiar age group because it is seen across all the age groups. More commonly, it is seen in the young adults. The common causes of acute liver failure includes paracetamol poisoning in the western continent, yellow phosphorus poisoning in southern India, and there are also viral causes for acute liver failure. Hepatitis B virus can cause this acute liver failure, hepatitis E can cause, hepatitis A virus also can cause, and mushroom poisoning also. In mushrooms, particularly a wild variety of mushroom, if it is accidentally, if it is consumed, can cause acute liver failure. And Wilson's disease in the children can present like an acute liver failure. Okay. And yellow phosphorus or a rat killer poisoning is an increasingly recognized problem, particularly seen in the young adults and adolescent age group. Particularly, you see that as a suicidal tendency, which can cause liver failure. It can cause also kidney failure. It can also affect the heart. So, early recognition of this liver failure as a problem and referring to a higher institutes where a liver transplantation and a liver specialist who are available in the ICU with a liver intensive care facility will help in salvaging these patients. Generally, the symptoms of acute liver failure in any yellow phosphorus poisoning is not seen until second or the third day. It generally starts off with jaundice, hypoglycemia, increasing derangement of liver function tests. INR or prothrombin time is a blood test which is done, which can get prolonged, and if the INR goes above 6 is a definite indication for a liver transplantation. And if the liver transplantation should be done at the earliest, because once an infection sets in a background of a liver failure, it is very difficult to salvage the patient. So, early recognition of acute liver failure and treating in a highly specialized liver intensive care units will help to salvage this patient, and liver transplantation is a successful modality for treating acute liver failures. And in the pediatric age groups, actually acute liver failure can be caused by accidental consumption of again yellow phosphorus or rat killer poison, and accidental consumption of medicines particularly called as warfarin. If the child consumes accidentally, it can lead on to this thing. Again, viruses can also affect children like hepatitis A, hepatitis B, hepatitis E can precipitate, and even hepatitis D virus also can cause, and cytomegalovirus can cause, herpes simplex virus can cause hepatitis, and the symptoms. Okay. If the interval between starting of jaundice and the starting of encephalopathy is less than 7 days, and if the prothrombin time is more than 100 seconds, there is a clear indication for a liver transplantation in this children. And there is one particular criteria which is called as King's College criteria, which is followed worldwide. If the child or an adult, if they meet the criteria based on the findings, they should be expedited for a liver transplantation, and a transplantation is a successful modality both in the adult and the pediatric age group. The success of the liver transplantation in acute liver failure is in the range of 70 to 80%, but liver transplantation should be done earlier before it is late. And late, I mean to say, once an infection sets in these patients, the success of the liver transplantation will go down.
So, there is a question,
okay.
Whether jaundice will lead to acute liver failure?
Not all jaundices will lead to an acute liver failure. Jaundice is one of the presenting symptom of an acute liver failure. So,
One
liver-
more question is there.
mhm.
What is the reasons for liver problems in children?
The liver problems in children, I said, as one is rat killer poisoning, accidental consumption, like if a rat killer paste is left in an area which need to be hidden actually, and if the child accidentally consumes that, actually can cause this. Again, hepatitis A virus can cause, hepatitis B can cause, hepatitis E virus can cause, herpes simplex and cytomegalovirus can cause, and accidental consumption of paracetamol can cause, and mushroom congestion also in children can cause this thing. And acute liver failure in a background of a Wilson disease, like acute presentation of Wilson's, is one of the causes for acute liver failure in the children.
That's it.
Okay. And once an acute liver failure is identified in any ward, they should be immediately transferred to a higher center which has got the facility for liver transplantation. Of course, liver transplantation should be the last modality when as a treatment to be offered for acute liver failure. First of all, what we should do is actually patient need to be seen by a critical care team with the medical physicians or hepatologist. Hepatologist is a primary physician who deals with this acute liver failure in presence of a critical care and nephrology and other team. It should be a teamwork in managing this patient. They should be referred into a proper liver intensive care or a pediatric liver intensive care unit, like the facility we have at Lakeshore Hospital and many other centers across in Cochin. They should be looked after by a team of doctors and team of nurses, and neurologists also should be involved, because patients can go into encephalopathy. They may require ventilatory support, and a neurologist should be involved in these patients, particularly because if these patients the coma is because of brain swelling or diffuse cerebral edema, and all the measures should be drawn to lower the pressure within the skull. Sometimes the patient who is there in the liver intensive care unit may require monitoring the pressure of the brain, called as it's a skull bolt which they insert, and through that a pressure monitor is introduced into the brain and pressure is monitored. And when the pressure is being monitored, actually the pressure should if the pressure is high, as evidenced by CT scan and a pressure meter, every attempt should be made to lower the pressures. While controlling the pressures, actually, if the patient or the children actually, if they meet the criteria for the King's College criteria, they should be considered for early liver transplantation. Most of these patients, they will also have some kind of a multi-organ involvement. They can get involvement of the kidney and they can get involvement of the heart, and patient may require continuous renal replacement therapy. Patient may also require ventilatory support, and they should be looked after by a special team of nurses, and particularly nurses who are trained to look after both the liver intensive care aspect and also the brain would be very helpful in monitoring the patient, because they keep looking at the pupils. They also look at the involvement of raised intracranial tension. So when these patients may also develop clinical signs like seizures, they should be monitored with the help of a neurologist, and anti-seizure treatment should be on for these patients, while treatment for controlling the raised intracranial tension also should be continued. They may require dialysis support in the ICU, and that dialysis is a very special form of dialysis, because most of the raised blood pressure is because of ammonia and other toxins which are accumulated because the liver has failed, and very intensive monitoring of the blood glucose also is required, and this prothrombin time monitoring should be very frequently done in the ICUs. Perhaps every 6 hours it should be done, and normally the prothrombin time is a marker for acute liver failure, whether they meet the criteria or not. Once the criteria is met, we should list them for a liver transplantation, and If there is an organ which comes from a cadaver transplantation program, if is available as a super urgent, actually the patient will receive the organ. If there is no suitable cadaver transplant which is available, then parallelly there should not be any delay, because either the close relatives like the first degree relative, father or mother, brother or sister or children, they should be evaluated first as a suitable live donor. The suitable live donor should be the same blood group, they should be less than 50 years of age, they should be healthy, they should not be obese, and the body mass index should not be more than 30, and they should be a very close relative or the first degree relative of the patient. In case if there is no suitable first degree relative in the family, it can be extended to the second degree relative. So, every attempt should be made to salvage this patient, because there is some precipitating event. There are otherwise they are healthy. Because of a precipitating event which led to this acute liver failure, there is a rapid decompensation and patient requires ventilator support and multi-organ failure, other things. So, we should do a transplantation before a multi-organ failure sets in and before an infection is there on the board, because once an infection is there on the board, even if you do a transplantation, the success of the transplantation will go to less than 50% actually. So, we should do a transplantation when the patient is well enough, and when the patients are there in the ICU actually. Every attempt should be monitored to see whether the patient shouldn't progress further actually. I mean to say, like, there can be a rapid deterioration because of raised encephalopathy, because of raised intracranial tension. They should be frequently monitored how they are mental neurologically, whether there is neurological deterioration. He may not be able to support his airway and his nutrition. He may require ventilator support, he may require nutritional support, and INR should be monitored as a clinical laboratory sign to see whether the patient requires a transplantation. And INR also should be closely monitored, because once the INR crosses more than 3, there is always a risk of bleeding from everywhere. I mean to say, the patient can bleed into the brain, they can bleed into the intestinal tract, or they can bleed from everywhere actually. So, the INR should be corrected only after having met the criteria, and once the criteria is fulfilled, when they are being worked up for the transplantation, then we can start correcting the INR. So
some questions are there.
Sure.
The first is, can liver failure occur suddenly?
It can occur suddenly actually in presence of an infection or an accidental consumption of rat killer poisoning or.
One more question. How effective the vaccinations are in liver disease?
Yes, it's a very good question, because hepatitis A, hepatitis B virus can cause acute liver failure. So, every attempt should be made to vaccinate for hepatitis A virus and hepatitis B virus actually. See, it is one of the preventive strategies which our national health program has adopted. All the pregnant mothers and all the children, even in the adults actually, when they don't have an adequate antibodies or if they are not vaccinated before, should be vaccinated to prevent these things. It's one of the ways of preventing an acute liver failure is by adequate vaccination.
Thank you, sir. And one more is there. For a person with acute liver disease, what are the intakes to be avoided other than alcohol?
Alcohol as a cause for acute liver failure is not a very, it's never seen, because alcohol can cause an alcoholic steatohepatitis or an acute on chronic liver failure. Alcohol is not a cause for acute liver failure actually.
Thank you, sir. Whether sepsis is a reason for failure?
Sepsis is a reason for multi-organ failure. Sepsis can never present as an acute liver failure. Sepsis can supersede an acute liver failure. Sepsis can happen in acute liver failure, and we should make every attempt to prevent sepsis in this patient. They should be monitored in a highly specialized intensive care units, monitored by very specialized liver nurses and team of liver doctors, which includes hepatologists, surgeons, critical care physicians, respiratory therapists, and an infection disease specialist in the hospital would always be very helpful, because he knows, the infection disease specialist will know the common like bacterial infections which can happen in the ICU. so that adequately an antibiotic cover is given to these patients to prevent any superseded infections to happen. They may also require antifungal cover in this patient. But despite doing all these measures, in case if there is no infection, if the patient continues to remain very if there is a very severe progression of prothrombin time, or if the toxins are accumulating in the body, there are ways to even do remove the diseased liver and put them on a portacaval shunt and then do a transplant when there is a suitable donor available. But of course, that can happen only in a toxic hepatitis, and toxic hepatitis is common in the pregnant age group in the ladies. It is because of autoimmune hepatitis. Autoimmune hepatitis also occurs in the men and even in the pediatric age group. And for a toxic hepatitis secondary to autoimmune hepatitis, you do a explant hepatectomy and then do a transplant within 24 to 48 hours when a suitable live donor is available. Okay. Yeah, acute liver failure is a growing problem, and particularly in the younger students, and this thing, every attempt should be made to educate these children not to consume rat killer poisoning, because it's one of the drugs which is commonly used for suicides and other things, and there should be increased awareness by the counselors